Good morning, everyone, and thank you for joining us today. On behalf of the International Bipolar Foundation, I would like to introduce Dr. Melvin McInnis. Dr. McInnis is the Thomas B. and Nancy Upjohn Woodward Professor of Bipolar Disorder and Depression at the University of Michigan Depression Center. He directs the H.C. Prechter research programs, and his current research includes following a cohort of 1,000 individuals in a longitudinal study of bipolar disorder and health unaffected individuals, a study that began in 2005. This research is among the most comprehensive research programs in bipolar disorder and includes extensive research in clinical, environmental, genetic, biological, and computational factors. This presentation will highlight the cutting-edge progress in these arenas. Dr. McInnis has published over 150 peer-reviewed articles on the genetics and clinical course of bipolar disorders. He is internationally known as an expert in the diagnosis, genetics, and clinical management of bipolar and depressive disorders in adolescents and adults. He was trained psychiatry at the Institute of Psychiatry, UK, and the Johns Hopkins University, and is a fellow of the UK Royal College of Psychiatry. Welcome, Dr. McInnis. We thank you for being here today.
Thank you very much. Thank you very much for the kind invitation to present here today. And I want to present my ideas actually on bipolar disorder, on affective disorders in general. And I'm not accustomed to talking necessarily on these sorts of presentations online. I'm usually talking in front of a crowd, and so you'll just bear with me here if in going from slide to slide. But I wanted to talk about what bipolar disorder is and what affective disorders are. Many individuals get confused about when psychiatrists and scientists talk about affective disorders, and I think that there's some ideas out there that I wanted to share with you that would be helpful in thinking through these illnesses. So the average person, when they interact with a doctor or a psychiatrist, they hear them talk about the concept of affect. And certainly when I was a resident and when I was in training, the concept of affect was somewhat difficult to understand for me. And so I wanted to share with you my journey in thinking about that. Also want to talk a little bit about some cognitive and psychosocial issues, risk factors, and then to end up with some interventions. And I have another a deck of slides that I can show you to talk more about the details of our research. My work over the years has been in the field of genetics, and the average person appreciates that mood disorders, bipolar disorder, and other mood disorders run in families. So there's a very strong genetic component to it. In fact, the heritability of an illness like bipolar disorder is probably in the range of 80%. And we measure that just by looking at families that have mood disorders amongst them. And over the years, over the past 20 some odd years in my career, we've spent our time looking for genes. And there are a number of genes that have been found, but the odds ratio is less than 1.2-fold. So it's a very minuscule risk that any one given gene contributes to bipolar disorder, and so that everyone believes and appreciates that there are going to be combinations of many risk genes that we have out there, and that the individual environmental risk, in other words, difficulties in relationships, substance abuse, or other problems in one's environment, actually confer a greater risk than any one specific gene that one would have. So this is a picture of the old graybeard that many of us will have in our slide deck. This is Emil Kraepelin, his claim to fame was that he distinguished between schizophrenia and the affective disorders. And he was a psychiatrist in Europe about 100 years ago. And in that era, they didn't have any real strong interventions. And so they were reduced to being caretakers of individuals with psychiatric disorders. And the advantages that they had then was that they were able to observe the course of the disease over time. So Emil Kraepelin, he proposed that affect, the concept of affects, has three components: emotion, volition, and intellect. Emotion is easy to understand. It's a sort of the happy, sad dichotomy. Volition is a little bit more complicated in the sense that it comprises energy, it comprises drive. Volition gets us up in the morning, gets the kids fed and off to work, or to start whatever it is but you're starting in the context of the day. Regardless of whether it's yard work, housework, or doing anything, volition keeps us going. Intellect in this context is not anything philosophical, but rather just the form and function of our thinking. So is the individual thinking fast, or too slow? Too slow, you're depressed. Too fast, one can be manic. Or is the content of one's thoughts positive or overly negative? So overly positive being in the manic range, and overly negative in the depressive range. So in thinking about affect, a number of years ago, I went to the Oxford English Dictionary and looked it up. And affect and its derivatives actually comprise around 6 or 7 pages in the Oxford English Dictionary. There's a lot of words that use affect as its base. And one of the basic words is affection. And most of us give and receive affection on a daily basis. And so if you think of a parent and their child, and so you think about volition, that we have the drive and the interest to care for our child, we have the love that we have for the child, and we think warm thoughts and speak to the baby in a very kind way. And so it's easy to think about affect in the context of affection. And I'm just going to go forward here one slide. And so affect, in the components of affect, they vary over the course of the day. So the average person will have a good part of the day, or a less than good part of the day, where they're they know that they're best suited to do their work first thing in the morning, and then they have a low period over the course of the day, and so on. And our affect fluctuates over the course of the week. We're in better spirits on Fridays as compared to Mondays. And so the whole nature of the features that we attribute to bipolar disorder is that they're present in the average person, and they vary in a very noticeable and recognizable way. So when we think about affect and affective disorders, and just in terms of volition as our drive and energy level, and thinking through bipolar mania, obviously has an elevated and misguided volition. People can do things that will get them in trouble. Depression, on the other hand, is lowered. The emotions of mania, one notices, of course, the elevations and the euphoria, the grandiosity. Depression being the opposite. And intellect, again, is obviously increased and grandiose in mania, and decreased and negative in depression. And so in thinking about that, in thinking about bipolar disorder in that manner, it helps us to understand and get information and delineate the features of the disorder. And so when we're teaching medical students, we like to give examples of an illness state in its extremes. And so on this slide, we see here the line there, the 5, and so that would be the line of euthymia. The average person fluctuates around that that balance of energy, emotion, and intellect. When you reach right up to the top, that's when a manic episode ensues, and the energies and everything of mania are right up there on the top. And on the opposite side, we see the depression, where the intellect, the negative thinking, the slowed negative thinking is right down there. Emotions are down, and volitions are right down in the gutter, and things are about as difficult from a depressive perspective as one could have it. So it's very helpful to think in those terms. So then we're thinking through bipolar 1 disorder, the recurrent manias and depression. And I already emphasized the elevations of volition, emotion, and intellects. And in major depression, the recurrent depressions cause all kinds of impairment, volition right down there with diminished drive, emotion, and intellect, everything's slowed right down. So this is just in text, what I was showing you on the screen in the figure. This is the point that I want. It's a slide that is perhaps slightly pejorative in the sense that it demonstrates it overly demonstrates the manic versus the depressive phase, but it's something that I emphasize for residents and for family members and for anyone who wants to learn more about bipolar disorder, and that is if one can just accurately describe what one is looking at, what one sees, that the individual is 70–75% there in just describing the mental status of the individual. And so on the left-hand side of the screen, you see someone who's dressed in a very manic way with large, exaggerated jewelry, large amounts of makeup, a little sign there, vote for me for the next president. So the grandiosity is there, and just the colorful organization or disorganization of things is really profound. Now, on the other hand, on the right-hand side, you see the patients in the same individual in a depressed state where their volition is diminished in the sense that they have no interest in or little interest in caring for themselves. Their clothes are tattered, and their mood is sad. They're not paying attention to their makeup or dress. So that's a very helpful slide. They use that to just emphasize the point that it's very important to make observations of the individual. Getting into a more challenging arena, we talk about bipolar 2 disorder, and that involves hypomanias. And so you remember on the graphs and the graph figure that I showed you, there is a line going from 0 to 10. So volition is a dimensional measure. It can have you can have a lot of volition or a little volition. So in bipolar 2 disorder, these features are elevated, but they're not elevated to the degree that they were in bipolar disorder, or bipolar 1 disorder. So a person with bipolar 2 can have increased volitional states, increased drives, increased productivity, but still under wraps, under an element of control. They can be seen as happy, elevated, cheery. Ideas flow, and in many ways, these individuals are very dynamic, very infectious leaders, and just very, very active in every way. And the question becomes, when does that therapeutic, when do the symptoms cross the therapeutic line? And so here you see again just a clear change from that middle line up into the realm of what we might consider hypomania, but it becomes a clinical judgment essentially as to when this might be considered problematic. So the real ability here, and the real advantage of what of Kraepelin's view of affect is in the components of this volition, emotion, and intellect. They're not always synchronized, and they can be considered to be in mixed states. In other words, in the classic sense, these individuals, they will often cycle in tune, or everything in sync. But if you think about the three components of affect, volition, emotion, and intellect, they may not always be synchronized. In other words, what happens when you have elevated energy and drive and elevated volition, yet low moods with negative thoughts? And so this is what is referred to as mixed states. And the problem with mixed states is that they have a challenge in their definition. You talk to a variety of different clinicians, and they will tell you that, well, you have mania and depression going on at the same time. And that's helpful, but it doesn't really describe very well what truly is going on. And there are all kinds of semantic descriptors. They call it irritable mania. They'll call it agitated depression, or a variety of different things, or just a mixed state. But this is what's really going on, is that you have an individual that has an elevated state of volition, so they've got a lot of energy going on inside them, and they've got a lot of dysphoric negative thinking. And so you have somebody walking around in a state like that, that they're energized, irritable, and they're angry and negative in thought. And so these individuals can be somewhat dangerous, in fact. And so a lot of untoward things occur in these states, wherein an individual will harm themselves, harm others, or get involved in acts that are very, very problematic. I wanted to talk a little bit about some of the risk factors from the cognitive theory of depression. So emotions seem to be influenced by the events in the world. And Aaron Beck, he talked about the cognitive triad of depression, a view of the self, the world, and the future. In other words, if you have a negative view of yourself, a negative view of the world, a negative view of the future, it's very difficult to be happy in the world. A series of other things that are problematic, sort of adverse early experience, rejection, pressure to achieve, exposure to childhood sexual abuse, for example, or just abuse in general, core beliefs that the individuals start becoming preoccupied with. I'm incompetent. Adverse events that lead to specific vulnerability that are specific to the vulnerability. So the feeling that I'm confident and not being accepted to their school of choice, a medical school or whatever school it would be. And then that activates a certain set of assumptions that therefore I am a failure. This generates a bunch of negative thoughts. I'll never succeed. A behavioral component comes in, low motivation, I can't do it. And then the depressive mood sets in that it is hopeless. In the 70s, there was a series of articles that came out of the UK, Life Events and Meaning. And this is work by George Brown and Tyrrell Harris. And this made every attempt to put life events together as a meaningful experience and putting meaning in what the life events have to the individual. And they identified a number of vulnerability factors that lead to loss, humiliation, and entrapment. And this was a common finding amongst depressed patients. And so there were variants that were core vulnerability factors. And so having a negative evaluation of oneself and being subjected to experiencing chronic anxiety and subclinical depression. And then there were variants that were indicative of social support, a lack of a confidant, lack of a crisis support system, negative elements in just in the core relationship with either with the spouse or the person that one is depending on for a core relationship, and just lack of adequate parental care as a child are also considered core vulnerability factors. And so this leads to a series of interventions and psychosocial therapies. And so cognitive therapy obviously confronts the negative view of yourself, the world, and the future. The example would be, it is true, I didn't get into the school of my choice, or I couldn't become a, whatever, but that means that that doesn't mean that I'm a bad person or an incompetent person. It means there are other things that I can do. And the world, yes, does have some challenges, but there are many good things about it, and the future likewise in a sort of similar manner. And so this approach develops a coherent narrative for the individual, understanding the problems in a new light and life events seen in the context of a variety of different vulnerabilities. Expressed emotion is also a phenomenon that really refers to the level of emotional tension in a family situation wherein there is intense verbal contact, criticism always is negative. You're a fill in the blanks, useless, blah, blah, blah kind of person, and you can never. And so when the individual is subjected to such criticisms all the time, it creates problems in that. So elevated expressed emotions in family settings are associated with early relapse of mood disorders and other psychiatric disorders. Childhood depression is another risk factor, and particularly in bipolar disorder. And the earlier the depression is apparent and problematic in the child, we pay attention to that because it is a strong predictor of developing bipolar disorder. And sort of in prevention strategies, I always say with a light heart that everything my grandmother told me happens to be true. And so there's in bipolar disorder in particular, regular routines are very, very helpful. Regular meals, regular exercise. Exercise is singularly one of the most important things in promotion of neuronal growth factors. And regular study habits, being good to one's family, and don't drink or smoke. These things are all very helpful. But they won't necessarily actually cure bipolar disorder, obviously, but they are, as noted here, risk factors. And so prevention strategies are family therapy sessions, potentially individual consultations when concerned about the child's or the parental health, and engaging the schools or other community resources to minimize and then mitigate the prevention issues. The medications that we favor are, of course, the mood stabilizers, antipsychotics, and antidepressants, anti-anxiety medications. So there are a whole host of medications that are particularly helpful and useful out there, and it's not really the purpose of this talk to go into those talk. So I'm going to use a talk that I actually gave yesterday. And so this is now to go into some of the features specific to the research that we are doing. I wanted to tell you about this is called the longitudinal in the long run. So why do longitudinal research? What are the resources that we have? Who should we study and how should we do it? I think that, so I wanted to say I'll be skipping through some slides because I only have around 15, 20 minutes left. But I want to emphasize longitudinal studies. I'm going to talk to you about a couple of examples of very interesting findings that I think are going to represent the future of research and the future of our understanding of bipolar disorder. But I wanted to emphasize the essence of the next generation of medical research. And so up until now, we've had individuals participating in research for short periods of time, and we ask the question, does drug A help condition B? And so we give and we randomize. Some people get active drug, some people get an inactive drug or the placebo, and then we measure the outcome over a particular period of time. And it's usually relatively short. The problem that we have with bipolar disorder and other illnesses is that it's a disorder that affects an individual beginning at an early age, and it affects them often throughout their lifetime. So we need to have participation of individuals with the disorder as the basis for future integrated medical research and translational research. We need to integrate technology and to enable individuals to be active participants in the collaborations for research. I also want to apologize. I think my screen may be a little bit off a little bit, that the right-hand side seems to be cutting off, unfortunately. So hopefully that won't jeopardize many of the points on the screen. I think it's about an inch or so off. Then, of course, we need the data systems and the structural infrastructure to gather the data and analyze it. Many of you will, especially those of you that a little bit older perhaps, and recall all the points that were made about the Framingham heart study. The Framingham heart study started in the 1940s, and they started by looking at around 5,000 individuals, and they began studying them for cardiovascular disease. And so everything that your doctor tells you about heart disease derives in some way from the Framingham heart study. Now, not everything we know about heart disease is from Framingham, obviously, but the advice that our doctors give us in the sense of not smoking, watching your cholesterol, watching your blood pressure, and sort of healthy lifestyle habits, all derived from Framingham. And it was this study that was very influential in the public health arena in the United States and around the world in managing and preventing bad outcomes in heart disease. So I'd like to see this happen in psychiatric disorders, in particular in the disorder that I study, bipolar disorder. So that's what we're on about here. Another picture here of Emil Kraepelin that I talked about. I'm a fan of his. He actually started long-term studies of psychiatric disorders over 100 years ago, and his work was highly influential and really forms the basis of our nosology of psychiatric disorders, and the DSM is really derived from Kraepelin. I am here in Michigan, and so this is our Michigan team on the right here, but we have a lot of individuals who participate in our research, and a lot of donors who contribute to our work, and clinicians who refer patients to us. And I'm just going to tell you briefly about the Heinz Prechter Bipolar Research Fund. It's an independent fund here at the University of Michigan, and our mission is to establish a biological and clinical repository for individuals with bipolar disorder as a base for research into the etiologies of bipolar disorder that include things like the genetics, the biochemistry, neuroimaging, and physiology. And we believe that by establishing this longitudinal cohort, that it will be able to allow us to form a base to for early detection and improved treatments of individuals with bipolar disorder. And so we're very grateful to the Prechter family for helping us with this. I'll jump over this, and on the right-hand side there, you see a picture of our lovely building. It's at the University of Michigan Depression Center, and I run a clinic here at the University of Michigan Depression Center that is a half-day clinic focused on bipolar disorder, where we all gather together and meet and screen and review patients. The clinic sees individuals throughout the week, but we have a formal clinic half-day a week. So this slide here really emphasizes the integrative nature of the work, and so there's a lot of big words there. Neuropsychology is just the testing of the ability to concentrate and think. Personality attributes are identified in psychology. We have individuals do event-related potentials, the electrophysiology. We do some metabolomics. Phenomenology, looking at impulsivity, and on the right there we see we're doing the genetics and the stem cell modeling and the clinical and environmental correlates of the work. So I want to go forward a little bit through some slides here, so hang on for a minute. And to tell you about the study that we're doing, the number of individuals that we have. So we declared just a time point 3 or 4 years ago and said, okay, we're going to include in the early cohort all individuals that were evaluated by 2000, the end of the year 2010. And if you look on the left, there's a bunch of descriptors of the rows there. Education. One of the limitations of our study is that we are here in a university town in Ann Arbor, Michigan, and so a lot of the people that live here are affiliated with the university or been to the university and have a higher number of years that they've been in school. So the individuals with the disorder, on average, they have 15 years of schooling, so that's the equivalent of 3 years of college. Their Wechsler IQ is slightly higher than average, and in the range of 110. So we're slightly unusual in the sense that we have a more educated group of individuals that are participating in the study. The advantage of that is that we have individuals who are very committed to the research with us. The other point is that individuals participating in research are often in their late 30s, early 40s. And so, and this is not unique to this study, but it's very similar in a number of different studies. So people often seem to have an existential moment in their late 30s and think to themselves, gosh, it would be really appropriate to study or to participate in some research and help us understand more about what is going on with this disorder. And we find that actually, if folks are, we interact with individuals in a way that we just let them know that they're our main collaborators in this work. Around 50 to 60% of them, or even greater, have a history of substance abuse or dependence. So there's a rocky road that individuals have walked down. I'm going to skip over this and go directly to what I think is a really interesting thing. And that is the stem cells that are a vision for the 21st century. Now, many of you will have read about stem cells and read about stem cells from a variety of different perspectives. It has been debated over the past several years. There are two kinds of stem cells. There's the embryological stem cells, which are really taken from products of reproduction, and then there are induced pluripotent stem cells. And so the induced pluripotent stem cells are cells that are really just derived from an adult, a piece of skin sample, or any other tissue for that matter, but can be coaxed into growing backwards, if you will, into an earlier stage of development, and then aligned with another cell type or an organ cell type and grown into to a cell that mimics another organ. So a piece of skin can be grown back to a primitive state and then coaxed into growing into either heart tissue or nerve tissue or things like that. So it's a very exciting way to study complex common human diseases such as bipolar disorder. And so it offers us a number of opportunities to study biology and the environment. And we think it's a base for personalized medicine, a personalized model of medicine. This is not a good one. Actually, no, that doesn't look good. Sorry. So how do we do it? So this is a very kind of a scientific process that I want to show you. Here on the left, you see things they're called fibroblasts. They come from the skin, and they're picked and they're treated with the things that are represented by OKSM, and those just mean factors, little things that are put in the culture of the skin cells or the fibroblasts, and the details are on the bottom there for those of you that have an interest in that. And then they form these wonderful iPS, induced pluripotent stem cell colonies, and they grow together and they behave in the manner that stem cells do, and they're grown in these cultures and treated with substances such that they grow towards neural spheres, neural being just from neurons, and then they're grown out and they form a particular pattern of growth called rosettes, and then they grow towards primitive neurons or nerve cells and mature neurons and glia. So all of this can take up to 12 weeks. So it's a very detailed and interesting process, a very specialized process. Now, the result of this is absolutely phenomenal. And working with the wonderful people in cell and developmental biology, they are artists. And they grow these cells and they stain them, and they can take photos of them that are absolutely brilliant and just so impressive. So what you're looking at there, for example, on the left-hand side, in both the red and the green, it's just a different color stain. So the little bright dots there represent the main nucleus of a nerve cell, and then the little stringy things, looks like spaghetti, represent fibers that are growing together, and they're reaching out to each other and interacting in a way that is that we believe to be similar to what nerve cells would do in the brain. The advantage of this is that we can get tissue from the skin and trick it into growing into nerve cells. And we think that these cells, because they're derived from someone with bipolar disorder, we can compare how nerve cells would behave in the brain of someone with bipolar disorder. So that's very, very important because we can't get nerve cells from individuals with bipolar disorder. So this looks like a funny scientific slide, which it is, but then on the B part there, if you look down, when I showed you one of those other cartoons, the iPSC, where the early stage cells, and then when they grow into neurons, they're more mature. The point that I want to make here is that the neurons, we have N1 and N2, it's just a set of individuals, and it indicates that the expression pattern of the genes is different in the individuals that have bipolar disorder versus those that do not. And that is very important. So there's something biologically going on that's different in the individuals with bipolar disorder compared to those that do not have bipolar disorder. I'm going to try this on my thing here. And this is another, if you can see my arrow here. So this is a line here, and the rate that this line changes is called a slope. And so you can look at how this how this line varies. So this is what we're looking at here is just a cross-sectional measure of how that is representative of how the cell behaves from an individual with bipolar disorder, with controls versus bipolar disorder. And so it's the slope of this line that caught the attention of the people in the lab, and saying there's a difference here in this slope in bipolar individuals compared to controls. And when you grow the cells with lithium, there's again a difference in this slope. So it changes. It doesn't make it like controls, but it changes it. So we found that to be very, very interesting. And it's indicative, again, of a functional change. In other words, how the cells are actually working with each other back and forth, that is different somehow in the bipolar individuals compared to those that do not have bipolar disorder. And so I'm going to click this button. You're going to see these cells light up. And so these are cells in a little dish that are firing. And so you can see that firing there. So that is something that the people in the lab really appreciate and really enjoy. And you can see they have little circles here, which means that they're just measuring the function of those particular set of cells in the dish. So the advantage of this is that we now have the ability to develop a little model, if you will, of bipolar disorder. So you can get cells from an individual with bipolar disorder, not from their brain, but from their skin, and you can grow them in a dish in the lab. It takes a good while to do it, but we'll get better at it. And we can measure how these cells operate. We can measure how they operate in the presence of specific medications like lithium. So that is of considerable interest, and it's very, very important to think about. I'm going to skip over this and that. And this is going to be, I think, our final slide. We're getting up to the quarter of here. Cells do not live on their own, and so there are cells that are called astrocytes. Nerve cells don't live on their own, so they have to have astrocytes, and astrocytes in the brain are like little pillows, if you will. And support the neurons, the nerve cells that communicate amongst themselves and help us to think and do the things that we have to do. But these astrocytes are the social support system of the brain, and they have to be there for the nerve cells to grow and look good. And this is a real crash course in how cells look, how cells are supposed to look. But on the top two quadrants, you see a bunch of sort of angular, sharp-looking cells there, and there are a bunch of little pieces there that light up a little bit more, light up greater, and they just look, for the scientist person, they look really healthy. And you can see little clumps of really shiny, bright, shiny things that are there. So these are the control pillow cells, the control astrocytes on the top two. And they're from healthy individuals without bipolar disorder. And so they have normal or unaffected neurons growing on the upper left and bipolar-derived neurons on the upper right. So the point is that they're really indistinguishable. So the bipolar-derived neurons grow nicely in the control astrocytes. And on the bottom, we have astrocytes, or the pillow cells, derived from the individuals with bipolar disorder. And we notice that even the healthy, or the neurons derived from unaffected individuals, or the neurons derived from bipolar individuals, they're less, they look less healthy, and they're less intense, and there are just fewer of them. So the story here is that the pillow cells, the astrocytes, are very important in the development of the brain. So with that, it is now 1/4 of, and so I just wanted to ask if you wanted me to talk about one more topic, or do you want to have a Q&A now? Question and answers.
Sure, excuse me, Dr. McInnis, you can touch on another topic, and then we'll go to questions.
Okay. So we have one, this is an older slide. We don't call it the Voices Project, but we call it now a Priori Project. But the second project that we're working with, and this is in collaboration with our colleagues at Computer Science and Engineering, and we are interested in determining if there are features, if there's a way for us to monitor individuals with bipolar disorder that will help us to predict when someone is heading for an episode. And so everyone, I'm assuming that 90% or more of folks on the line have a cell phone or use a cell phone on a daily basis. So you're walking around with a little computer on you. So that computer could be used in a manner to help monitor the illness that one has, whether it be bipolar disorder or other disorders. So we're working with computer scientists to capture speech on a cell phone and process it very briefly on the phone, and then send it to the data system, to a central server, and to see if there are features in the data to identify changes in the speech pattern that would predict when the individual is heading for an episode. So this is important because in bipolar disorder, when the individual becomes hypomanic, and I showed you what that was earlier on, the insight and the ability to be reasonable about getting treated is often very diluted, and to the point where the individual says, no, I don't think I want to have that happen to me. I don't want to get treated because this is such a great state. And so they may go on to subsequently do things that severely compromise their personal, their social, and their vocational life. So personal, they can run into problems at home, and marriages can go south. Social, they can annoy their friends and relatives to the point of being isolated and lose friends and lose family relationships. And vocational, just losing one's job because of untoward productivity in the workplace. So it's very important for us to be able to treat and manage individuals with bipolar disorder. So if we feel that if we can identify risk factors in advance, that would be very helpful. The other thing that's important to appreciate is that those of us that have tried to do these online sort of applications, monitoring one's mood over time to look for change patterns. I mean, I tried it myself, and I found that I could only do it for 2 or 3 months, and that was real determination. That. So in our clinics here, people will do these things, very briefly, and says, I don't want to do this anymore. And so we wanted to have something that can be used and be functioning without the individual having to do anything. So that's the hypothesis there. So we, gather speech in patterns, and you can see these green lines here, and that's when somebody's saying something. So there's a number of data points in the speech, and so it can be the energy of the speech. There can be things like jitter and shimmer that define the patterns of the sound waves. So it's not the content that we are interested in at all. We don't really care what the individual is saying, but we're just interested in how they're saying it and what are the features of the speech that are there. And so it's like when we talk to a family member of a person with bipolar disorder, and they will say, Dr. McInnis, there was something in the way I knew there was something going on. I could hear it in their speech, I could hear it in his speech or her speech. And then, a week later, they were, everything went bad on them. So there's something in the speech that is there, and these are another just examples of different acoustic patterns that we're looking at. But I just want to show you this slide because I grew up on a farm, and the lesson that my father taught me on the farm is that you have to know the sound of a well-running machine. So if you can know the sound of a well-running machine, you can pick up when something is amiss. And so the arrow, the thing on the right, is a bearing. And so on a combine, for example, a bearing will go bad, and you'll hear a squeaky noise, and then it'll go away because the bearing just wears out and the axle goes, and you've got a few minutes or an hour, whatever operating time before something really goes bad. So it's very important to pick things up in advance of them going wrong. And anyone who either has bipolar disorder or knows someone with bipolar disorder will appreciate that very, very much. And of course, anyone who works around farm machinery or other machinery appreciate that as well. Now, this is a kind of a representation of what I'm interested in seeing. So if you look at the arrows that are pointing up, and if you have any particular measure that's going on there, you can see that there's, of course, there's variability in the person's speech. Some of us, when we get mad, our voice changes, and when we're happy, our voice changes, and so on. And so with our family members and folks in general, we can usually tell what kind of mood they're in, with how they're speaking. So there's variability in the speech. But if you look at, the lines, lines between the arrows there, you can see there might be a slight change in the slope or the angle of if you draw a vertical or a straight line between those two arrows and say, well, there's something that is subtly changing there. So in the first arrow, you could say, well, would there be a 30%, 40% chance of them developing something? Second arrow, well, it's going to be a little bit more likely, maybe a 50%. But by the time you get to the third arrow, you're right there at a 90 to 95% chance of something going wrong, and then poof, the speech goes up, and then things go really bad. So if you can identify the individual who's at risk at an earlier phase of some kind of an acoustic change, they could come into the doctor and get treated. So that is our hypothesis. And so with that, I will stop and just offer the opportunity for questions and answers. So in summary, I really just summarized really for you how we think about bipolar disorder in the context of affect and volition, emotion, and intellect. I've summarized for you the importance of longitudinal study and the opportunities that the Heinz Prechter Fund here at the University of Michigan is offering us here, and we're very enthusiastic about this work. And I've summarized for you two of what I think to be, our most exciting research projects, and that is the work that's done with the collaboration at the Cell and Developmental Biology Laboratory with the scientists there, Sue O'Shea, and at the Computer Science and Engineering Laboratory here at the University of Michigan with the scientist whose name is Emil. So we're very enthusiastic and excited about the work here. So thank you very much.
Wonderful. Thank you so much for that very informative and interesting presentation. And I apologize for the feedback. Our first question reads, what is your best guess on how many years it will take to have tailored medication recommendations based on genetics?
Well, many years ago when someone was conjecturing something, they said, well, if you say 5 years, then that just means eternity. You know, it's hard to say. So I think that based on the trajectory that we have had over the years, that we're still a ways away from that. And so although with the technology emerging with the stem cell work, it may very well be that in specialty situations that we will be able to, special situations, we may be able to develop programs that will be specific and personalized for the individuals. And so I can't really look into my crystal ball other than I can say, based on the patterns that we've had in the past, that we're at least 10 years away from something that would be meaningful at this level in bipolar disorder.
Wonderful. Thank you very much for that. Next question. Are you seeing any identification of strategies that might delay or prevent onset of bipolar disorder, important for families with severe bipolar?
So I think that strategies can be many and varied. I always emphasize for an individual who comes into the clinic and they are, a younger person and they're working very hard to manage their illness and manage their situation, and they are not drinking alcohol at all or smoking marijuana or doing anything that will compromise their state, and they've got a good set of parents and they've got a good situation. So I emphasize to them how fortunate they are that they don't have the substance abuse monkey on the back, and then how fortunate they are that they have one or two parents that are really working very hard for them, and that they need to appreciate the the wonderful things that are going on with that. For the individuals that are and so, I just emphasize, do not go and even think about having, starting drinking. There's no point for you to go out and have a drink, really, in that sense, because you're not really interested in doing it anyway. So don't even think about starting it as a social intervention. For the individuals that have other, risk factors, be they, challenges with their relationships with their moms and dads, or challenges with their relationships with their friends and their spouses or whatever. The emphasis then goes on how you can maximize and strengthen those primary relationships. How can you, and if there's an issue of substance abuse, how can you maximize the likelihood that you will not be using alcohol or depending on alcohol or substances? And if there's a situation where the individual is has a disruptive lifestyle in terms of waking late, or how you can put regular features into their life. I emphasize that tremendously. And then finally, the importance of the collaborative effort between the people providing the care, the physicians, nurses, social workers, and psychologists, and the individual and the family is really truly emphasized. So it's not any one particular thing, but emphasizing the good and identifying trajectories that will maximize healthy living.
Great, thank you. Our next question. I was surprised to mention antidepressants. Is that a last resort, given that it could increase mania symptoms?
So the I apologize. I'm just getting over a little bit of a cold, and so when I talk for a longer period, sometimes I get a bit of a cough. So the antidepressants have been debated intensely back and forth in the management of bipolar disorder. The point that I always emphasize is that we have individuals with bipolar disorder for whom the primary problem is a really bad depression. And in a scenario where the individual has, had a manic episode 10, 15 years ago and has been struggling with depression over the past several years, uh, an antidepressant can be a very helpful intervention for an individual in that set of circumstances. Now, and in anyone who has any substantial history of bipolar disorder, and when I mean substantial history, a history of being admitted to hospital for bipolar 1 mania, that is someone who clearly has the illness. I would definitely recommend managing that with a mood stabilizer, lithium Depakote or Tegretol, or potentially an antipsychotic if that is what's being used. So some medication that has a mood stabilizing effect is critical. And then if the prevailing mood is depression, then certainly consideration with monitoring of an antidepressant is very, very important. It can be a very important relief for the individual. The important thing is monitoring the individual going forward. The important thing is making sure that the individual appreciates that this is not without risk, and to educate both the individual and the family for that. But the author of the question is spot on, and I'm very pleased that that level of awareness is out there, because an individual with bipolar disorder who's just given an antidepressant by themselves, it can be a very problematic situation and precipitate a mania. The other challenge is in the individual who has a history of what is believed to be bipolar disorder, but may have occurred in the context of using substances, taking amphetamine or smoking marijuana very intensely or drinking intensely, and then the psychiatrist or the physicians, in the wake of a binge of substance abuse says, you might have bipolar disorder. So, but there was no clear history of anyone having, or the person having a bipolar manic episode without being stoned or something. So that individual, there may be diagnostic complications or diagnostic challenges yet that may challenge whether or not the individual has, in fact, bipolar disorder or not.
Great. Thank you. The next question, how close are you to completing the phone technology, and shall we assume that is smartphone only?
Yeah, so it's a smartphone thing. So thank you. We're actually just in the process of, we're 1 year into a grant. We were very fortunate to have had some resources here from the institution and from the federal government to sponsor this work. So we're 1 year into the federal funding supporting this work, and we have several hundred hours of acoustic or of speech gathered from individuals, and we're now looking into how far back we can predict mood changes. And so we hope to, this work is being presented in a speech conference in the engineering world in a month or so. And so we're hoping that in the next 3 years that we will be able to deploy this further into the world. We are very excited about it. There are all kinds of other measures and metrics that one can use to monitor individuals or allow oneself to be monitored. But we're hoping that this will have a shorter time to utility, because it's just so very interesting and exciting, actually. And yeah, I think it's going to be one of the ways that we're going to be able to provide extensive health care for our population. I mean, if we can use technology to monitor individuals, and you just develop an index and say, gosh, you have a X percentage likelihood of developing the disorder, that's going to be great. But 2 to 3 years, I think we'll be able to have this more actively deployed.
Wonderful, thank you. That is very exciting news. And I wanted to say thank you for joining us today. It is time to check out, and thank you, audience, for participating, and have a wonderful day.
Thank you very much.